Hello everyone. In this video, we are going to learn about viral exanthems, basically diseases which are caused by viruses which cause a rash in our human body. These diseases tend to be particularly common in children but can affect other age groups as well. So let's begin with a clinical scenario, because now that's how most of the questions are framed in, especially in the AIMS entrance postgraduate entrance examination, and even in the NEET PG. So let's read the question. So the question says that there's a girl, and she's an ill-appearing child who presents to us with a mobiliform rash with erythematous macules and papules. So there is a rash, and it's an erythematous rash with macular papular lesions basically, and they first appeared on the face and the neck, and now it has spread to the trunk and extremities. And when you examine Sabrina, especially her mouth, you find something as the bluish white dots which are there on the mucosal surface of her mouth, and they look something like this. Now I'll add some other details. That the Sabrina, she's a 1-year-old female, and on top of that, she has not been immunized. In such a scenario, you have a child who comes to you, 1-year-old, who has not been immunized, with a erythematous maculopapular rash that began on face and then has progressively spread to the trunk. And then you have lesions, these particular lesions, which I'll explain to you later what are, on her mucosal surface of the mouth. Now, what's the clinical diagnosis that we're going to make? The 4 or 5 options that I'll present to you are: it's a drug eruption, erythema infectiosum, measles, roseola, or rubella. The answer to this question is, as you might have guessed by now, measles. Measles is a very common illness, used to be a very common illness when vaccination was not there, and that was a clue that I gave to you. She's a 1-year-old female, but she has not been vaccinated. So a child who has not been vaccinated presents to you with a rash, a mobiliform erythematous rash that starts in face and then spreads throughout the body. That's the classical presentation of how measles presents. Especially the rash actually tends to start behind the ears. That's what's classically been described as measles, that the rash tends to start behind the ear and then spreads cephalocaudally. Secondly, measles tends to most commonly occur in the 6 to 12 months, usually in the 6 to 12 month age group, and that's why the measles vaccinations tend to be given at 9 months. And that's very important, because especially if there is a measles epidemic, the measles vaccination can be given even as early as 6 months. Now, why don't we give measles vaccination before 6 months? It's simply because till 6 months, the child maternal antibodies that have been transferred from the mother to the child can protect the child against measles, and that's why the measles vaccination is usually given around 9 months when measles tends to start to occur. So measles as a disease is caused by the measles virus. It belongs to the family Paramyxoviridae, and it has an incubation period of 10 to 12 days. So you get exposed to measles on, let's say, day 1. On 10th day, you'll have the first symptoms of measles, and the incubation period is 10 to 12 days. The first symptoms usually is in the form of a febrile illness. These all viral infections causing rash are associated with a febrile illness. So the first time the fever might start was on the 10th day of the illness. And the rash typically appears 4 days after the appearance of the fever. So this is also a question that has been asked in MCQ, single word answer that can be asked in your entrance examination. Has been frequently asked previously, that how many days after the appearance of fever does the rash appear? So rash tends to occur on the day 4 of fever. That's what's been typically been described as the rash of measles starting to appear. So you have the incubation period of 10 days. Around 1 to 2 days later, you have something known as the Koplik spots. These picture that I was describing, this small bluish white dots that appear on the mucosal surface of the mouth, that's what been classically described for measles as the Koplik spots. These Koplik spots tend to occur specifically above the second molar region of the child. That's where they first tend to appear and then spread through the entire oral mucosal surface. So for measles, what you need to realize is that first you'll have an incubation period of 10 days, important for a single liner MCQ. The rash tends to appear 4 days after the onset of the fever, and then you have something of a prodrome, which is basically a coryza-like picture. The child will be feverish, will be coughing, might have some conjunctivitis, might have some dry cough, won't be feeling well, malaise might be there, and after 4 days, then you will have your rash, and the red rash itself will fade around 4 days later. So And before the formation of the rash, 2 days before, you'll have something known as Infantum, in which case of measles is the complex spots which I showed you earlier. They tend to appear on the especially above the second molar first. So 4 things that you need to remember about measles is it's a viral illness. That's first. It's a viral illness caused by a measles virus which belongs to the family Paramyxidae. Second, the incubation period is very important. The incubation period of measles is 10 days. The rash appears 4 days after the measles. The complex spots appear before the rash around on the second day after the fever. These are the 4 things that you need to remember. Other things that are important as far as measles is concerned as an illness, that the rash first, like I told you before, tends to occur behind the ear and then spreads throughout the body. First tends to occur on the face and especially behind the ear, and then spreads throughout the body. And later, what's more important is it's a vaccine preventable disease. The vaccine is first given at 9 months of age. The reason, in the first 6 months, the maternal antibodies which have been transferred from the mother to the child can protect against measles, and after that they have been progressively going down in the child. In case of epidemics, if there is an epidemic that's occurring, then the measles vaccine, which is typically given around the age of 9 months, can actually be given at the age of 6 months as well. That's also an important question that you need to remember and has been asked previously. Now, how is it diagnosed? The diagnosis is basically clinical. You will have this typical presentation of a child who's, let's say, around 1.5 years old age, not been vaccinated, comes to you with a rash, complex spots, had a febrile prodrome of fever, cough, malaise before, and then has this typical presentation to you, and that's how it's diagnosed. But if you want to do some serological testing, then anti-measles IgM and IgG antibodies are available, and you can also isolate the measles virus for the identification of the measles RNA. It's an RNA-based viral, Paramyxidae family. Also, if you do the histological evaluation of the skin lesions, you'll find giant cells, and these giant cells have both intranuclear and intracytoplasmic inclusion bodies. It's more important from a microbiological point of view. These have been taught to you in microbiology, just being revising you as well. It results in formation of what is known as the syncytial keratinocyte giant cells, and they are also known as the Warthin-Finkelnday cells. Warthin-Finkelnday cells. More important from microbiology point of view, just revising your from that. Now, usually it's a self-limiting illness, but the problem comes is that the measles can cause profound immunosuppression, especially the cell-mediated immunity takes a hit when you have measles, and that's why they are at a risk of a lot of complications. And these complications are usually superadded bacterial infections. The most common of them is the otitis media. So if somebody asks you which is the most common superadded bacterial infection that occurs after measles, it's otitis media. The answer is otitis media. But however, which is the most common fatal complication? So you can actually die from measles also, not exactly from measles per se, but the complication that occur because of measles. The most common fatal complication is pneumonia, superadded bacterial pneumonia. Measles by itself can cause a viral pneumonia-like picture in which is known as giant cell or Hechet pneumonia. So if somebody asks you, there are 2 different questions, which is the most common complication of measles. The first answer is the most common complication is otitis media, a superadded otitis media bacterial infection that's occurring. Because, why? Because measles virus causes a depletion of your immune reserves. Basically, it causes immunodeficiency, especially profound cell-mediated immunodeficiency is what's been caused by measles virus. In your PG entrance examination, especially for PGIMR, there can be a question which of the following causes cell-mediated immunodeficiency. The first option will be given you HIV. That's obviously true. The second option will be given to you will be measles, and measles also causes cell-mediated immunodeficiency as far as the cell-mediated immunity is concerned. That results in superadded bacterial infection. The most common is otitis media, but the most common fatal infection is pneumonia. Measles itself can cause a viral pneumonia-like picture. That pneumonia is known as the giant cell or Hechet pneumonia that has been frequently asked previously in your entrance examination. Management, since it's a viral illness, there is no role of any antibiotics. The illness typically is self-limiting. However, since it causes profound immunosuppression and it tends to affect the cell lining per se, vitamin A supplementation has been shown to be very effective as far as measles is concerned. So vitamin A supplementation is known to be of benefit in treatment of measles. Second, as I told you, it by itself causes immunosuppression. The child is already immunosuppressed because of being malnourished, because he's taking care in inadequate supportive care. That can aggravate the problem and lead to complications. Management mostly self-limiting, give antipyretics and ensure adequate hydration. No role of any antibiotics per se in measles. That itself, because measles will get cured by itself, and then you have lifelong immunity. What's more important is prevention. Measles is a easily vaccine preventable diseases, so make sure that the child is immunized for measles at 9 months. Again, I'll reiterate what I've been saying before. Measles vaccination can actually be given at 6 months of age in case of a measles epidemic is there in the community. Now let's move on to the second clinical scenario, another viral exanthem. Now this time there's a child called Jatin. He comes to you and he has fever and he has a rash and sort of painful ulcers that are present in mouth, hand and feet. The diagnosis becomes very clear by itself right now. What's more important, that he's up to date with his vaccination. So let's say, since he's up to date with his vaccination, if somebody gives you in the options that whether it can be measles, that sort of gets ruled out, whether it can be rubella, that again sort of gets ruled out. So these two options get ruled out, and the clinical picture itself explains to you what the disease is Jatin is having. He's having fever along with some painful ulcers on his hands, on his feet, on his mouth. So what is the diagnosis? The options that are given to you is whether it's varicella zoster, whether it's hand, foot and mouth disease, whether it's herpes simplex, whether it's porphyria cutanea tarda, or whether it's a simple aphthous ulcers. So the aphthous ulcers tend to occur only in the mouth. They do not tend to occur in the hand and feet region. The herpes simplex virus does not cause such kind of clinical picture in such a 6-year-old boy. Porphyria will have photosensitivity, which has not been mentioned, and varicella zoster is what causes chickenpox. Chickenpox will typically have a truncal presentation rather than a presentation on the hands and the feet. They are typically spared in case of chickenpox. So in chickenpox is ruled out because typically hand and the feet are typically spared. Aphthous ulcers occur because of a vitamin deficiency, particularly vitamin B deficiency. Remember, he's staying in South Delhi. Now South Delhi is typically an affluent region. He's up to date to his vaccination. So you can sort of rule out aphthous ulcers. Porphyria cutanea tarda will have a photosensitivity like picture, which has not been particularly mentioned. So the option is very clear in this case. The answer is hand, foot and mouth disease. The typical presentation, flow grade fever, the hand and the feet and the mouth are being involved. Why is it important? Because this picture was particularly asked in the AIIMS November 2017 exam. They gave you the exact similar clinical scenario and asked what's the disease. The answer was as obvious, the hand, foot and mouth disease. As usual, again like a viral exanthem, it will have a prodrome consisting of fever, sore throat, malaise for 1 to 10 days, and then you'll have an exanthem, and these exanthems are pink macules and papules, and these vesicles which tend to ulcerate and then resulting in lesions which are typically, as the name suggests, hand, foot and mouth. With an exanthem, there is always an enanthem. These oral lesions are, they resemble sort of the aphthous ulcers and called canker sores. The distribution is what is typical. First starts in mouth, then progressively involves hand and then feet. Occasionally buttocks, the diaper area and the elbows may be involved. What's more important is what causes hand, foot and mouth disease. This has been asked in your NEET 2017-18 examination. So there are 3 viruses that have been typically implicated in hand, foot and mouth disease, that are Coxsackie A16, A6 and enterovirus 71. These 3 have been typically implicated in hand, foot and mouth disease, out of which enterovirus 71, the disease caused by enterovirus 71 is typically much more serious and sometimes can even be fatal and will have a presentation that is different from this viral exanthem, might even present with aseptic meningitis like picture or encephalitis. While CVAs, those who have been caused by Coxsackie virus 16, they will appear uncomfortable but are not toxic, that is, they are not septic looking and not that serious. Typically tends to occur in late summer and early fall. Incubation period is of 4 to 6 days. These details are not important, let me tell you that. What's typically asked in an entrance examination is a clinical scenario that I just presented to you. What's caused, what is the disease? It's hand, foot and mouth disease. What causes it? It caused by viral, like I told you, it's a viral exanthem. Coxsackie A16, A6 and enterovirus 71 are the most commonly implicated organisms. Enterovirus 71 causes a much more severe disease as compared to A16 and 6 and tends to occur more in the summer, around summer and around fall. What is the management? As like other viral illnesses, is self-limiting illnesses, then tends to be resolved within 10 days. However, it's highly infectious, so treatment is usually supportive. You have to provide antipyretics and anti-analgesics to the patient. Make sure that he's in a contained environment so that he prevents there is no spread from one person to another. Another scenario, this is the third clinical scenario that I'll give you. This is of a Karan. He's an 8-year-old boy. He's up to date with his vaccination. He's having a low-grade fever several days ago, and now the fever sort of has resolved, and after the fever has resolved, he has red cheeks and a rash on his body. And this is a typical how Karan is looking. He is having this rash on his body. Now what does this resemble? Imagine someone slapping you and then you having this reddish kind of erythema on your face, and this is sort of a rash that is clearing in the center. This is what is a typical presentation of, if you're giving these following example: Drug-Eruption, erythema infectiosum, measles, Roseola, Rubella. Like I told you, it's up to date to his vaccination, so measles and Rubella are immediately ruled out. Drug-Eruption, there is no history of any drug intake, so drug-eruption is also ruled out. Now this typical slab cheek appearance is what's characteristic of the erythema infectiosum, and that's the answer if this question has been asked to you in entrance examination. Now erythema infectiosum is caused by what is the virus called parvovirus B19. What's very characteristic of this parvovirus B19 is it's a single-stranded DNA virus. And what the typical clinical presentation is like it has been described to you in the clinical scenario, that he had a fever, and later after the fever he had this rash and these red cheek. This slab cheek appearance is very characteristic of parvovirus B19 and the disease, the erythema infectiosum. And the rash, it's a typical lacy pattern like rash. As you can see, the rash has a lacy pattern with a central clearing that's going on. A reticular lace-like eruption that tends to be there on trunk and the extremities, and this rash tends to fade over 1 to 4 days. What's more important for parvovirus B19, that the typical illness, the erythema infectiosum, actually is a self-limiting illness like other viral exanthem, but the complications are much more severe. What we typically know and has been asked multiple times in entrance examination, that parvovirus B19 causes typically what is known as the aplastic crisis. Why it causes this aplastic crisis is because it specifically affects red cell production. The progenitors of the PRBCs, the progenitor RBCs, it halts their production, so it causes what is known as the aplastic crisis, which becomes much more severe, especially if someone is suffering from a hemolytic anemia like a picture. For example, someone who's suffering from hereditary spherocytosis, the aplastic crisis in hereditary spherocytosis typically caused by parvovirus B19. How it spreads: respiratory tract secretion or a percutaneous exposure or a vertical transmission from mother to fetus. I'll explain to you later why this is important, that a vertical transmission to mother to fetus. Incubation period of 1 to 2 weeks, and the child is typically has a fever and then a rash. A particular serious form of the disease is called papillopurpuric gloves and socks syndrome. Now what will happen, that the rash will become purpuric, petechule, will start to sort of bleed. The child is very contagious, and people who are at risk should not be around the child who is having this purpuric hand and glove syndrome. So this is not purpuric hand and glove syndrome is basically nothing but a very severe form of the disease where the erosion become painful, pruritic, and sometimes petechial, and sort of bleed. What are the complications? The first complication I have already mentioned, of someone who's having a hemolytic anemia. It can cause a transient aplastic crisis because it tends to halt the production of the PRBs, the progenitor RBCs. The second one, like I told you, the most common mode of transmission is the respiratory secretion, but it can also be transmitted from the mother to the child through the placenta. Now what happens because of that, that is one of the common causes of non-immune eye drops. A child having eye drops, the most common cause in a country like India is Rh hemolytic disease. The mother having a negative blood group, Rh negative blood group, child having a Rh positive blood group, and because of that the Rh hemolytic disease. That's the most common cause of eye drops in a child in a country, and a developing country like India. However, if the child has non-immune eye drops, that is the mother, there is no ABO incompatibility, there is no Rh incompatibility. One of the common causes of non-immune eye drops is this parvovirus B19 expression. Because this parvovirus, if it infects the fetus, there it can cause this lysis, this halting, this aplastic crisis that will result in anemia, further leading to intrauterine growth retraction, heart failure, that heart failure further complicating with pleural and pericardial effusion. and there is a risk of fetal death between 2 to 6.5% when this infection occurs during pregnancy. Let's move on to the next clinical scenario. This is a Kamal. He's a 9-month-old male. He comes to you with fever and rash. The fever this time, the fever that I'm describing in this clinical scenario is of up to 40 degree. Basically, it's a very high grade fever, and later, after the fever has resolved, the child again has a red rash on his trunk that has progressed rapidly. He's up to date with his vaccination. He's 9 months, but he has been vaccinated. Again, we can easily rule out measles in such a scenario. So this is how the red rash is looking like. It first appeared on the trunk. Fever had occurred, fever had stopped, then the rash had suddenly occurred, and the fever typically is of 40 degrees Celsius. Basically, it was a very high grade fever. The fever lasted for around, in the scenario I'll add, for around 5 days, and later the rash came. Based on the history and examination, what is the clinical scenario that I'm presenting to you? Measles is sort of ruled out. Like I told you, erythema infectiosum typically tends to present with a rash that is there on the slap cheek rash, that is there on the face, and has a particular lacy pattern. So that is not there in this clinical scenario. This is now how they tend to present, and they do not tend to have this very high grade fever that is characteristic. Rubella is ruled out. The answer to this question is Roseola. Now Roseola, also known as Roseola infantum or Exanthema subitum, the clinical presentation is something like similar that has been occurring like a viral exanthem, but the fever is very high grade. It's typically in the range of 39 to 40 degrees Celsius. It's so high grade that it's many times tends to present with a febrile seizure-like illness. So if you have been given a clinical scenario in which child has fever, has a febrile seizure, and then also has a rash, the answer is most likely going to be Roseola infantum, because the high grade fever tends to precipitate the febrile seizures. Most characteristically, the rash tends to appear after the fever has subsided. That is, when the rash is there, the fever is not there. In most other illnesses, when the rash is there, fever is in the subsiding phase, but fever is still there. In this case, the fever has mostly subsided, and it's called, that's why it's called Exanthema subitum, because it essentially means a sudden rash. The parents or the clinician might believe that the fever has subsided, the child is fine, but suddenly the rash will appear. And the rash consists of pink macules and papules surrounded by white halos, and typically begin in the trunk, as compared to measles on rubella, which tend to occur on the face first. It will typically appear on the trunk first, and as compared to, let's say, the parvovirus B19 causing erythema infectiosum, it does not tend to involve face, does not cause that typical slap cheek appearance. The rash lasts for around 1 to 3 days. What's more important for your entrance examination, what causes roseola? Roseola infantum. Roseola is caused by human herpes virus 6, HHV6, less commonly by HHV7, human herpes virus 7. Tends to occur in children 6 months to 4 years. There is no vaccine. So if someone is saying the child is vaccinated, so you can at 9 months, according to the Government of India guideline, the child should be vaccinated with MR right now. That is measles and rubella vaccine right now. So if a child who's like 1 year old comes to you who hasn't vaccinated, so measles and rubella you can rule out. Erythema infectiosum you can rule out because he won't have the slap cheek appearance. Drug eruption, in this clinical scenario, you can rule out drug eruption because there is no preceding history of any drug. You can rule out measles and rubella because he has been vaccinated. You can rule out erythema infectiosum because that the fever was very high grade, 39 to 40 degree, and secondly, did not have that slap cheek appearance that is characteristic of erythema infectiosum caused by parvovirus B19. What's more important is that it's caused by human herpes virus 6. Less commonly, it's caused by human herpes virus 7. There is no known vaccine, and immunity lasts forever. The last one that I'm going to present to you is rubella. Again, rubella has a clinical prodrome of a fever, headache, sore throat, rhinorrhea, coryza-like picture. Sometimes there might be conjunctivitis and lymphadenopathy, and it also has an enanthem. Told you about Koplik spot. Koplik spot tend to appear on the oral mucosa, especially above the second molar. If something similar to Koplik spot that occurs on soft palate and uvula, that is very characteristic of rubella, and that's called the Forsheimer sign. So if they're going to give you a clinical picture of an oral mucosa, if it's occurring on the mucosal lining around the molar region, that's what's very characteristic of measles. But if it's showing on the soft palate and particularly on the uvula, that's the Forsheimer spots. That's not the Koplik spots. And secondly, how is rubella differentiated from measles? That in measles, like I told you very characteristically, the rash tends to appear 4th day after the onset of fever. However, here the rash tends to appear very suddenly as soon as the fever appears. Typically on day 1 or 2 itself, the rash tends to appear. Does not take around 4 days as compared to measles for the rash to appear. Again, the treatment is very supported. Now, why rubella is important is not because of the fact that disease per se can cause something. In case of measles, because of the profound immunosuppression, it can cause pneumonia or otitis media like picture. However, rubella by itself is a very self-limiting disease. Why it's important is because if rubella occurs during pregnancy, it tends to lead to what is called as the congenital rubella syndrome, the CRS. Now, congenital rubella syndrome causes intrauterine growth rate syndrome and a host of congenital anomalies which have been frequently asked in your entrance examination. Now, what are these permanent manifestations? There is a typical triad. The first one is of hearing impairment, the SNHL, the sensory neurone hearing loss. Second, of a congenital heart defect. The most common amongst that is PDA. That has also been asked, which is the most common congenital heart defects in a child who is suffering from congenital rubella syndrome, the CRS. The answer is PDA. What is the most frequent manifestation? That is SNHL, that is sensory neural hearing loss. Along with that, then you're going to have eye defects, which can be in the form of cataracts or in the form of a pigmentary retinopathy. Along with that, it causes microcephaly and central nervous system sequelae in the form of mental and motor delay and autism. There can be certain transient manifestation in a child who has congenital rubella syndrome, typically known as the blueberry muffin syndrome, because the child will have hepatosplenomegaly, thrombocytopenia, and this thrombocytopenia will precipitate a dermal erythropoiesis, causing a blueberry muffin-like picture in the child. Along with that, bony radiolucencies, meningoencephalitis, IUGR. These are the transient manifestations that tend to go away, but the permanent sequelae, the typical triad, consists of eye, ear, and a congenital heart defects. This is a typical triad that has been described for congenital rubella syndrome. In the heart, the most common congenital heart defect is the PDA, a patent ductus arteriosus. Hearing impairment is the sensory neural hearing loss, and the eye defect, the most common, is consists of a pigmentary retinopathy, closely followed by cataracts. That's why rubella is most important. Rubella can easily be prevented by a vaccine, RA27/3. Nowadays, the government of India recommends vaccination at 9 months by the MR, the measles and the rubella vaccine, followed by at 15 to 18 months of age by MMR. The reason we tend to vaccinate against rubella is not because rubella by itself is a very, it's like any other viral disease, just has an exanthem, has a viral rash. It's in fact, rubella is called German measles because it very closely resembles measles. Just that its course is a bit more protracted. Measles has a longer course, while rubella has a very shorter duration of course. Rash tends to appear just as the fever appears. The duration of illness is smaller. Something very similar to measles, but it has a very significant impact on the fetus just in case a pregnant woman contracts it. So the reason we tend to immunize and vaccinate against rubella is to protect these children from having this congenital rubella syndrome, because the permanent sequelae are very damaging to the child. They are sensory neural hearing, the typical triad I'm repeating again and again because I had been asked multiple times in an entrance examination. The hearing impairment, the congenital heart defect, and the eye defect, which can be either cataract or a pigmentary retinopathy. Along with that, it also causes microcephaly and CNS defects. Thank you.